The big picture are Sir Harry Burns, the former Chief Medical Officer for Scotland, Professor Marcus Longley, who's Vice Chair of Cardiff and Vale Health Board, a Welsh equivalent of what's known as an NH Trust in England, and Dr Amanda Doyle, who's Chair of the NHS Clinical Commissioning in England, which works with groups of MPs who allocate spending on patients. Good afternoon to you all.
Hi.
Hello there.
Hi.
I wonder whether I could start off with the most obvious question. Is this all about money? Is it, I mean, obviously there are other things, but is it really about money? Dr Amanda Doyle.
It's not all about money. We are struggling to cope with the increases in demand within the health service. More money would help, but actually part of the issue is that the way we do things isn't in the best way that we could for a modern health service. So changes in demand, changes in our ability to deliver treatments, higher tech interventions and medicines mean that we need to deliver care in a different way.
Well, I'd like to look at
finance is an issue.
I'd like to look at some of that in a moment, but Professor Marcus Longley, how much do you think it's money?
Well, it definitely is about money, but it isn't only about money. I think that's right. And the issue, I think, is that we all know about the rising demand from an ageing population, and we in this country have chosen to spend significantly less than most other countries on healthcare, and ultimately you get what you pay for. I think the other issue about money is that to make the sort of change that the health service need often requires upfront investment. It requires investing in the new system before you close down the old. So it's that double whammy, really, of not enough on a long-term basis and not enough to make change happen.
So Harry Burns, do you agree with that?
It's not so much about the money as how the money is spent. We're currently talking about spending money on treating illness. The definition of health from the World Health Organization is health as a state of complete physical, mental and social well-being, not merely the absence of disease or injury. And we don't really pay enough attention to demand management through increasing well-being in the population. There is no question that a whole range of small projects that have been run in the UK over the past few years have shown that social change has helped people cope better with their lives and significantly reduced demand for a whole range of public services.
And Dr Doyle, we heard on Monday about one approach which was more, I guess you'd say, holistic. It was trying to bring together and not just treat people as somebody with a heart disease and then go and see another specialist for their diabetes. I mean, is that approach something that's fruitful?
It is. With a group of largely elderly, very frail patients with more than one complex long-term condition, the most effective way to treat people is not to treat each individual illness separately with a range of hospital appointments and admissions in and out of A&E. So what we've been working on locally is a holistic approach to well-being and health, and keeping people well and independent in their own home, which is having significant impact on the number of attendances and admissions to hospital for this group of patients. But as we've said, you've got to set these services up before you see a reduction in hospital attendance. So there is an issue with financing these services up front, which makes it difficult to scale up very, very quickly.
And Professor Longley, today we've heard about a more local sort of health service. Do you think that would work?
Well, to some extent, that's what we've got in Wales and in Scotland and Northern Ireland. It has been devolved, and it offers the opportunity, I think, to get closer to the needs of individual populations. But it's by no means a panacea. That some of these relentless pressures on the health service still exist, whatever level you make the decisions.
And I'd like to hear from each of you what maybe it isn't one big idea, maybe that's not a fruitful path to go down, but if you've got one thing you would change, you'd want to implement that would really help, what it would be. So, Harry?
There is no one thing that you can do. What I would want to implement was a process by which we took learning from all the places that were achieving demand management and managing things appropriately and scale it up, learning across the system, not just seeing small projects, however successful, blossoming and then dying because of local shortage of money or whatever. Let's get a learning culture across healthcare where we learn and implement the change.
Professor Longley, what one thing would you do if you could?
Well, I would do everything everybody else has said. I think also, though, there is a notion about the health service being what we call in Wales more prudent. So the health service spends a lot of time and effort doing stuff that really doesn't add much benefit to patients. You get on a conveyor belt, you have a whole series of tests, you end up in hospital, and that's often because nobody sits down with the patient and says, well, what would really make a difference in your life? End-of-life care is another classic example where we pile in and do lots of things to people for no benefit. So if we can put some brakes on that, I think the health service would probably end up saving a bit of money, and it would certainly end up providing better quality care for people.
Dr. Doyle, earlier you gave us a list of things you think should be done. Would you like to pick one or two of those and expand on that?
So I think actually there's three big things we need to do. We need to rapidly scale up our efforts at prevention. We need to tackle those things which we know cause huge burden of disease, like alcohol, like smoking, like obesity. We need to look at the way we deliver health care services for people when they're ill. So we need to look at how we configure services so that they're giving us the most clinically effective as well as cost-effective outcome. And then we need a proper conversation about what is the level of funding we actually need to deliver a 21st century health service that can meet the national standards. And the national targets have been set for very good clinical reasons. So we need a proper conversation about the level of funding that's needed to actually deliver services that perform well enough for the standards that we want in this country.
So, Harry, I'm hearing quite a lot of agreement among you three. I mean, what do you think the political obstacles are in getting some of these things done?
Politicians, and I'm caricaturing here, but politicians tend to want to have a grand idea that they can take credit for success with and so on. There is no one big grand idea going to change this. It's going to be doing lots and lots of small things, all of which are effective, which together will add up to a step change in terms of prevention of ill health, in terms of creating a sense of self-efficacy and local control over one's health and its determinants. That's going to be a slow process. It's going to be quietly happening in the background, and politicians aren't going to have anything to shout about, and therefore they still look for the big strategy that they can take credit for having delivered. But maybe I'm just being hard on politicians.
Professor Longley, is he being too hard on politicians?
No, I think politicians are in an almost impossible position, aren't they? We've got appalling austerity, which is going to go on for as long as anybody can predict. So this is not the time to be saying we want to spend more money on anything. But the harsh reality is, you do get what you pay for. It's 7% of GDP in the UK. It's 10% in most other countries. So, that's a huge issue. And that is something which potentially the politicians can solve. A lot of the other issues are for the health service and social services to solve themselves. But the money that they are given ultimately is a political decision.
Dr. Doyle, what is the balance between something that doctors can do for themselves and something that needs political will?
I think it's a combination of all those things. It's what patients can do for themselves. It's what clinical staff, NHS staff can do to work with patients, and it's political will to make all of that happen. It's worth saying that a lot of what we do now is the right thing to do. Our primary care service has long been held up worldwide as an example of a really effective service. The problem we've got is demand is rising at such a rate that those services no longer have the capacity to deal with all the demands. And so we need to expand the capacity, and we need to look at more effective ways. So there's huge benefits to be had from really properly investing in technology and ways of working that are supported by the technology that's available, that the NHS has got nowhere near using as effectively as lots of other industries do.
The technology is a very interesting question. What are is that something, Sir Harry, that could make the future look a little bit brighter?
No, I don't believe so. I draw an analogy with the British cycling team. They tried lots and lots of things, all of which produced small marginal gains, and when they did them all consistently, they got a step change in performance. And I think that's true of every complex system. I don't think there's going to be any magical new technology emerging that's going to solve the problem. I think it's doing lots of things that work consistently, knowing you do them, and being supported to do them by senior management.
Professor Longley, it seems I'd sit here every week reading out gloomy headlines about the NHS and targets missed. How pessimistic or optimistic are you about the future?
I think we could have a really good system, and it requires quite a lot. There are real challenges about scale and pace. You know, there are lots of good things happening across the health service, but how do we get the scale and the pace behind that change? I think, you know, the most likely future, I'm afraid, is one where things just gradually get worse. We get a bit more shabby, a bit more difficult to access services. We cut this little bit and we cut that little bit. That, I think, is unfortunately a fairly likely scenario looking into the future.
Professor Marcus Longley, Sir Harry Burns and Dr. Amanda Doyle, thank you all very much. Now to the case of the mysterious disappearing